All right, folks, so today I'm going to be discussing diabetes mellitus. So let's start off real quick with the organ that we'll be discussing today. And the organ is known as the pancreas, but we're talking about the endocrine function, not the exocrine function. So keep in mind that there's two cells within the pancreas that are not functioning well in diabetes, and I'll discuss the difference between type 1 and type 2 in just a bit. So in the pancreas has what we call alpha cells, and it has beta cells. Make sure you guys remember that alpha cells are the ones that secrete glucagon, which increases blood sugar levels by converting the stored form of glucose in the liver, known as glycogen, into glucose. And this happens when you're not actively eating and your blood sugar drops below its normal level. And let's remember that normal blood sugar is anywhere from 70 to 110. Some books might give you a slight different variation from that, but it's consistent when it comes to 70 to 110. It's always around there, right? Now, that's a fasting blood glucose level. So again, your alpha cells release glucagon, which increase blood sugar levels by converting glycogen into glucose. And then we have our beta cells, and the beta cells release a hormone known as insulin. And insulin decreases blood sugar levels, kind of working like a key that opens up the cell and it allows the glucose to go inside, and then the cell therefore utilizes the glucose for metabolic respiration, for metabolic function, for metabolic function. These are the two hormones that we're going to be discussing in diabetes, type 1 or type 2. So let's differentiate real quick. In type 1 diabetes, we have an issue of zero insulin, okay? Or the amount of insulin that's being produced or released by the beta cells is so insignificant that the patient needs insulin injections to maintain metabolic function. And there's also zero glucagon. Okay, so again, these two hormones in a healthy individual, they help maintain normal glucose levels. When your blood sugar gets too high, insulin is released, blood sugar goes down. When you haven't consumed any food and your blood sugar starts to drop a little bit, glucagon is released, and then blood sugar then increases. Well, this is the issue with type 1 diabetes. You have none of those, and it usually happens early on in life. But today, I don't like to emphasize so much on this being insulin-dependent diabetes mellitus, even though the books do discuss it as being IDDM, insulin-dependent diabetes mellitus, because the patient with type 1 diabetes needs insulin so they can decrease blood sugar levels, meaning they need insulin injections. And that's the only way that their blood sugar levels are going to be regulated. And the only way that they're going to be increasing blood sugar levels is by consuming food. So your patient with type 1 diabetes is a lot more sensitive. This patient has a likelihood of developing abnormal blood glucose levels much more so than your type 2, which we'll discuss in just a bit. So in type 1 diabetes, let's recap. Zero insulin, zero glucagon, or the percentage of both of those hormones that they are producing is not significant enough to maintain metabolic function. It happens early in life, okay? And it's considered insulin-dependent diabetes mellitus. However, it's important for you guys to understand that today we have different populations that they require insulin injections even when they don't have type 1 diabetes. That's why the book discusses this as insulin-dependent diabetes mellitus always, but your type 2 may sometimes require insulin injections as well. So, your type 2 diabetes, a little bit different. This is more about lifestyle. When you have type 2 diabetes, you have some insulin. You have some glucagon. And this sum that I'm talking about, it could be, 90% of what you're supposed to have, and these patients don't necessarily manifest any symptoms of diabetes mellitus. But as the body begins to get abused, as you consume foods that have high fructose corn syrup, or as you continue to eat fast-acting carbohydrates, well, the demand on the pancreas is increasing, and that fatigues the pancreas, the islets of Langerhans, the alpha, the beta cells, and eventually they stop releasing as much insulin as they once were able to. Another thing that happens is something called insulin resistance. And insulin resistance is the phrase that we use to describe when the cells, in order for the sugar to go inside the cell, you need insulin, right? You need insulin to help lasso in that sugar so it can open up the cell and the sugar can go inside the cell so the cells can carry out cellular activity, right? But what happens with this yo-yoing of you consume food that has a lot of fructose corn syrup and then your body releases a lot of insulin, well, the pancreas becomes fatigued and these cells kind of become desensitized a little bit to the abundance of insulin that's consistently being released. It's kind of like, ladies, it's kind of like when your boyfriend says, I'm sorry for whatever he is accused of doing, right? Eventually sorry works. I mean, initially sorry, I apologize works the first, maybe the second time. But eventually I'm sorry is useless. It no longer works. That's kind of how this happens. The insulin is released so often that the cells are like, yo, you know what? I'm not feeling it anymore. I'm not going to be receptive to this hormone that's asking me to open up, just like you ladies will not be receptive to accepting your boyfriend's apology, right? It kind of works the same way, and that's called insulin resistance. So keep in mind that the medications that we use to give for these patients, they primarily deal with either increasing the already functioning amount of insulin that's being released. We can, like glipizide. Glipizide normally increases the release of insulin from the pancreas. We also have other means of maintaining glucose levels with type 2 diabetes. We can give something like metformin. And metformin, what it does, in order to reduce glucose levels, it slows down the conversion of glycogen into glucose. So it exerts its effect on the liver. And then you have other medications that decrease the absorption of the glucose into the circulatory system within the gut. The reason why I'm talking about this so early on is because you need to understand that your patient with type 2 diabetes, once that percentage of available insulin starts decreasing to the point that we need some assistance, before we start giving insulin injections, we start giving medications. We start educating our patients to carry out exercise, because exercise lowers blood sugar levels without the use of insulin. And that's really important for you guys to understand, because the more you exercise, the less load of work that your pancreas has to exert to output all that insulin. So that's why it's important for us to teach our patients to exercise. But exercise has to be a little careful. We have to be a little careful with exercise when we already have patients who actively have chronic ailments such as diabetes, because it can lower the blood sugar levels into less than 70. It can cause hypoglycemia, which we'll talk about in just a bit. Continuing with type 2 diabetes. Again, these patients have some insulin, some glucagon. It just depends on what lifestyle they have, whether it's going to maintain the percentage of insulin that it's still releasing, or whether it's going to wither down and become so low that it requires some additional help. And we talked about insulin resistance. That, in a nutshell, folks, is the difference between your type 1 and type 2. Eventually, type 2 diabetes will require some insulin injections when that percentage of those hormones of insulin starts decreasing. And food consumption, or snacks, or carbohydrates, both simple and complex, become very important, which we'll discuss in just a bit. All right. Now that we've explained the main difference between type 1 and type 2 diabetes, let's talk about clinical manifestations. When these patients are not consuming food adequately, their blood sugar drops. Now, generally speaking, when we have hypoglycemia, okay, I want you guys to revisit the theme that I'm trying to propose to you guys, that your body's clinical manifestations of any condition is more or less your body doing something to fix that issue. So we said that sugar is required for cellular activity, right? For our cells to be able to utilize the glucose for action, for metabolism, for the cells to work, right? Well, your body activates a different mechanism so it can generate some type of energy when the glucose levels fall below the therapeutic values. And when that happens, you can think about hypoglycemia is essentially fight or flight. Okay? It's the activation of your sympathetic nervous system. Okay? You can memorize all the details of hypoglycemia. We can say the patient has a headache, the patient has a rapid ready pulse. So they will have tachycardia, in parentheses. The patient will be diaphoretic. Okay, you'll have cool / the diaphoresis, clammy skin. This is what's happening to your patient that has low blood sugar levels. But instead of memorizing all the details of hypoglycemia, I want you, they're also gonna have nervousness, okay, irritability, okay. We can focus on each one of these clinical manifestations, and if you can memorize it, that's great. But instead of memorizing all this stuff, we can just remember that the hypoglycemia activates your sympathetic nervous system. That's your fight or flight. Why do you have a headache? Because your cells, your neurons don't have enough glucose to maintain function, so you have a headache. Rapid thready pulse, the activation of fight or flight so your cells can have some degree of energy. Because remember, when you're hypoglycemic, you'll also have weakness. You'll also have blurry vision. Okay? This is all caused by the lack of sugar in your cells. So your body tries to do something to give you a boost of energy. And how does it do it? By activating fight or flight. Headache, rapid thready pulse, tachycardia, diaphoresis, okay? Cool, clammy skin, because when you have sympathomimetic action, you have peripheral vasoconstriction, which pushes the blood to your vital organs, right? That's the whole fight or flight. And that's what gives you your cold and clammy skin. You're gonna have nervousness. You're gonna have shakiness. If you guys recall the last time you scrapped, last time you guys got down, last time you guys threw down, your hands get really shaky when you're that pissed off, when you have adrenaline running through your system. And that's why these patients that develop hypoglycemia, they develop nervousness, they develop irritability, they develop tremor, shakiness, because their body is full of fight or flight. You're gonna have irritability, you're gonna have weakness, because your cells don't have the energy that they require to function normally or adequately, but we have all this fight or flight. And then you'll also have blurry vision. So keep in mind, those are the clinical manifestations of hypoglycemia. Now let's talk about the treatment of hypoglycemia. Generally speaking, you have two types of patients. You have your conscious patient, and your conscious patient is the one that's awake. If your patient is awake, you can give them a fast-acting carbohydrate. Your body's main fuel source for glucose is carbohydrates. Well, we have two basic types. We have simple monodisaccharides, and we have complex, your polysaccharides. So what ends up happening is, if this is your esophagus, here's your stomach, and here's your small intestine and your large intestine right here, right? When you consume food, let's say you're eating white rice, okay? White rice is very starchy, doesn't have too much fiber in it. And when you consume it, it comes in here, it goes inside the small intestine, and it goes all through the small intestine and then large intestine. And the white rice, the carbohydrates within the white rice get broken down very easily and absorbed fairly easily, and the patient's blood sugar goes up really fast. That's your initial response when the patient is hypoglycemic. You want to get that glucose level out of the red zone. You want to make sure that if it's 40, 50, 60, you want to get it back into the 70 or above range. And you do that with a simple carbohydrate, okay, with your white rice. But then you want to maintain glucose levels. You want to give them something that is more complex in its nature, that will be absorbing glucose little by little to maintain glucose levels. And that's when your complex carbohydrate comes into play, like give them a sweet potato. Give them something that has fiber in it, because that's gonna be slowing the transit time as it passes through the small intestines. And that means that the glucose is gonna be released into the bloodstream little by little, and that glucose is gonna be maintained in its therapeutic value. Because the white rice is short-lived. It'll give you a burst of sugar, but then it drops again because we have no more. But keep in mind, when you give them the complex carbohydrate, it maintains that glucose level. So there's an abundance of elements that are in our food that are considered simple carbohydrates. Make sure you guys research those, because we don't know what the question is going to ask you. We don't know what the possible options are going to be for the simple carbohydrate, but just understand they're simple carbohydrates, and usually juice will do. Be careful though when you're giving juices to your patients that have diabetes, because if you're giving citrusy juices that contain potassium in there, you may cause an increase in potassium values, and these patients might also have comorbidities such as renal issues, because diabetes eventually causes kidney issues, nephropathy. So you gotta be careful when giving them juices or foods that contain a lot of potassium in there, because it may cause hyperkalemia, which is a whole other problem within itself. It's gonna affect your ticker, your heart. Now, that's what we do to the conscious patient when they're awake. And we also keep monitoring that blood glucose to ensure that the patient's not going into a diabetic coma. Then we have an unconscious patient. Your unconscious patient, they can't receive anything PO. You have to be mindful of that. Your unconscious patient is going to receive an IV solution. They're going to be receiving dextrose. They're going to be receiving glucagon. Any of those medications is perfectly fine for your patient who is unconscious. You're going to give it to them parenterally. You're going to ensure that the patient receives it parenterally, and then we check the glucose level, and hopefully they come back awake, because that's the issue with your unconscious patient, that the patient may develop, might slip into a diabetic coma, and we don't want that. That's generally speaking how you treat hypoglycemia. Let's talk about hyperglycemia now. Remember, hyperglycemia can also happen to your patient that's given too much of dextrose or glucagon or your simple or complex carbohydrates, but it's easier for us to treat hyperglycemia than to let some time pass by while the patient is hypoglycemic. So we can correct the issue of hyperglycemia a lot faster than we can hypoglycemia. So we want to make sure that we pull that patient out of that red zone of being hypoglycemic. Now let's talk about hyperglycemia. Hyperglycemia is a little bit different. Let us pretend that we have that these are your blood vessels, right? This is a representation of the blood within your system. And inside we have glucose, because we have a patient who has hyperglycemia, right? And how does hyperglycemia develop? The patient doesn't take their insulin, they eat too much food, they're drinking soft beverages, they are consuming too much of that high fructose corn syrup, which spikes your glucose levels up really high, really fast, right? Well, let's pretend that these right here are the representation of your body's cells. Now, there's no cells like that outside of the blood vessels. We have some inside, right? But these are the representation of your body cells. And so remember, we have to keep in mind that your body will try to fix whatever issue is going on, and that's going to give you your clinical manifestation. So in this case, we're talking about hyperglycemia. Blood sugar is really high. What happens? Well, the first thing your body does is it starts pulling water out of the cells into the bloodstream so it can dilute the hyperglycemia, so it can dilute the sugar. That's what your body does. Now, your body's not supposed to do that. The intracellular compartments are so sacred. We don't want to be pulling water out of there. That maintains hydration, right? That's where you have the most abundance of fluid within the body. However, your body tries to do something to fix this issue of hyperglycemia. It pulls water from the cells, it dilutes the blood glucose level, and that gives us our first P, polyuria. You guys have heard of 3 Ps, right? This is why it happens. Your body pulls in water from the system, it puts it inside the vessels, and now you have more circulating fluid. Your glomerular filtration rate increases. You have more fluid going to the kidneys. Hence, your urine output also decreases. And that gives us your first P. The second P is going to be polyphagia. Well, right now in this scenario, we have hyperglycemia. We have no insulin around, right? And the patient has a lot of fluid inside the blood vessels. But the cells are still starving. They have no glucose in there, because what are we missing? We have a lack of or a decrease of insulin, and that's why the cells are starving. So that's polyphagia. The patient's hungry. And then because you've removed the fluid from the cells, which we don't want to do, Now you have things like your mucous membranes that become dry. Essentially, you're dehydrated and you're very thirsty, and you have polydipsia. These are your 3 P's, folks. Those are your 3 P's. They occur because of that. Your body's attempting to fix this issue of hyperglycemia. Now, generally speaking, when somebody has diabetes, whether it's type 1 or type 2, your type 1 diabetes is a little bit more sensitive, like we discussed earlier, because complications can occur a lot faster with this one because they have 0 of both of those hormones. So we have to act quick with your type 1 diabetes. They can develop something called diabetic ketoacidosis. Now, this doesn't mean that it only happens to type 1. No, it happens to type 2 also. But type 1, it happens a lot faster because how much insulin do they have? None. And type 2, it takes a little longer for the DKA to develop, and I'll explain why in just a bit. So generally speaking, folks, when you have type 1 or type 2 diabetes, your cells eventually become starved because of hyperglycemia, the sugars in the blood vessels not inside the cells. So your brain sends, like, your cells send a little signal to, like, your brain, okay, and it says, hey, I'm hungry, I'm starving. Your brain says, I got you. I have a way to fix that. So your brain signals for fat and muscle, which is made out of protein, right, to be broken down so it can get more sugar, so it can get more energy. But is that what we need right now? Do we need more sugar? No, we need insulin. But I'm trying to describe to you what's happening in the body and these complications. So in diabetic ketoacidosis, what causes that is that, again, your cells are starving, you're polyphagia, polyuria, polydipsia. Your brain signals, hey, let's break down that body. So your fat gets broken down into its basic components known as fatty acids. Your muscles, proteins get broken down into its basic components as well, known as amino acids. Now we have a bunch of acid in the bloodstream. This is a new thing. These little red dots represent the acid. Okay? And it happens to be working hand in hand with the waste product of breaking down fat and muscle, which you guys know as ketones. So when we break down fat and muscles, they give off a waste product known as ketones, which are also acidic. And I'm gonna draw these little triangles all over here. I'm drawing triangles because they have sharp edges. And ketones, which remind me of stones, what happens to, you get a stone and you rub it on your arm? Doesn't it break it down? Doesn't it scratch your skin? Well, that's what happens when the ketones swim through the blood vessels. They destroy nerves and blood vessels. And this is why my Uncle Chepe had a bilateral lower leg amputation, because of the bad vascularization, bad neuropathy, and then the patient can no longer feel things well. So, diabetic ketoacidosis is this emergency situation where your body starts breaking down its own fat, its own muscles, it releases acids and ketones into the bloodstream, and now you have an acidotic condition. This is known as diabetic ketoacidosis. Essentially, it's metabolic acidosis. Okay? Now, we have that. Now, you guys have probably heard of this, and the patient will have a fruity odor in the breath or an acetone breath, right? Let me explain why this happens. You guys recall the last time you did some gastric residual with your patient. If you smell it, it does smell a little fruity. I guess that's a good way of explaining it, at least from my perspective. So, when the patient has diabetic ketoacidosis, they have metabolic acidosis. And what did I say the theme was? When somebody has an active problem, your clinical manifestations is your body trying to fix the issue, right? Well, if you think of compensatory mechanisms, what happens when you have metabolic acidosis? What system can help get rid of acid? Your lungs. And that's when the patient will develop their Kussmaul breathing. Their Kussmaul breathing is the patient's respirations become deeper, they start exhaling more. And what their body's trying to do, what their lungs are trying to do, is they're trying to get rid of that carbon dioxide, because carbon dioxide happens to be acidotic, right? It's acid. And your body's trying to fix the issue by blowing off some of that CO2. And when you smell it, it tends to be a bit fruity or acetone in odor. And that's what happens in a nutshell in diabetic ketoacidosis. Now, there's another condition that may develop for type 2 diabetes. but type 2 diabetes alone, only. When you have a patient who has type 2 diabetes, we already discussed the hyperglycemia. We talked about the 3 Ps. I have to draw this again because I should have left it there. But so we have our blood vessels. We have the same scenario. We have hyperglycemia. And the same situation is happening. These represent the cells. And same compensatory mechanisms. A body pulls water from the cells, right, to fix the issue. Now, in type 2 diabetes, you can have this scenario working as well, but in type 2 diabetes, you have some insulin. Now, that's some maybe 90%. In this condition, it's not going to be 90%. It's going to be like 40% of the available insulin that the patient can release into the bloodstream. But they have some insulin, so your cells don't necessarily become starved. I mean, they're hungry. They're not receiving as much sugar as they need to maintain metabolic function, but they're receiving some insulin, so they don't starve. They don't send that signal to the brain to break down fat and muscle. So your biggest concern is going to be dehydration. And this condition is called hyperglycemic hyperosmolar and since there's no ketones because the body's not breaking down fat or muscle, it's non-ketotic syndrome, or HHNS or HHNS. I swear, as the years go by, the abbreviations and the names slightly differ, but it's the same concept. You have hyperglycemia, you have hyperosmolar, you have a lot of fluid being pulled out of the cells into the bloodstream to dilute the sugar, but you don't have any ketones, and it's this syndrome, it's this condition. And I want you guys to be very clear on the idea that this patient's main issue is dehydration. Okay, so yes, we want to give them insulin injections, absolutely. But we want to address the issue, the elephant in the room. Everybody focuses on give him insulin, give him insulin. Yes, but we have to hydrate that bad boy. We have to hydrate that patient because the biggest component is that we're having cellular dehydration. This can lead to a lot of other complications, and we don't want that. So because of that, we have to hydrate the patient, and that's going to be your main focus. For both patients, whether it's type 1 or type 2, we need to give them insulin. And when it comes to insulin, there's different types, okay? We have your regular insulin. We have your Aspart, your Lispro. Now, Aspart and Lispro work really fast, but don't last as long as regular. But just understand that both of these are similar. These two are almost identical. Regular is your bread and butter for insulin. It's the same type of insulin that your pancreas releases, right, in theory. But you also have Aspart and Lispro. And Aspart and Lispro work a little bit faster, and their peak time is a little bit sooner than your regular, and it doesn't last as long. And of course, we have these available because some patients have really uncontrolled diabetes, especially in this country. And so we have to have some little tricks in our back pocket, some medication to give them in these specific situations where the blood sugar goes up really fast. We have to bring it down, sometimes a little bit faster than regular insulin would do it. So we have regular insulin, we have Aspart, Lispro. And by the way, your regular is gonna be either Humulin or Novolin, but it's going to have an R in it. So it'll say Humulin R, Novolin R. That's how you know it's regular insulin. Humulin and Novolin is just describing where they derive the insulin from, but the R is what lets you know it's regular insulin. Same thing. And with Aspart, it's or Lispro, it's very similar. It's going to have I call them the logs. It's either Huma or Nova log, and that suffix is how you know it's these two extra fast ones, right? And that's how you know whether they're Aspart or Lispro. And then we have our are NPH. Okay, NPH is your cloudy insulin. NPH is your intermediate acting insulin. And you also have medications like Glargine or Lantus, same thing. I don't know if there's an E or not. Glargine, yeah, maybe just like that. But these are there's more insulins than this. There's more insulins than these. But these are the main ones, folks. So you have your long-acting insulins that have no peak. You have your NPH that are considered intermediate, and then you have your regular and aspart/lispro. Now, why do we have to know these insulins? Well, in the context of nursing, you guys have to understand what's your role as the nurse. If somebody received any of these, what do? What do you have to look out for? And because of that, you have to memorize your onset and your peak times of all of these insulins, okay? Make some room real quick. Make sure you guys pause the video and get these down. These are the most important ones. When somebody receives insulin, the onset time lets us know when does the insulin begin to work. The peak lets us know when the medication is working at its highest effectiveness, which may lower the blood sugar a little too much, and we have to look out for low blood sugar levels, right? So this line represents the strength of the insulin, okay? 1, 5, and 10. And down here you have time. So let's work with regular insulin, okay? You guys have to know the onset and the peak times. Now, this is your job. This is your information that you have to memorize. You have to go into that ATI book, into the Saunders book, into the Kaplan book, into the Davis book. I don't care what book you use, but you have to use those books because that's what's going to give you the values that we're really looking for when it comes to ATI and NCLEX examination. But I'll give you guys the common ones. Your onset for regular insulin is usually 30 to 60 minutes, meaning that it begins to work. The insulin's effectiveness starts increasing and your blood sugar starts decreasing within 30 to 60 minutes. And the onset's very important for any of the insulins because this is what's going to tell you when you feed the patient. When should the patient be eating? That's what the onset, is really about. If you see a question about onset, we're talking about when's this patient going to eat. Then you have that first bite within this time frame. And the peak time is probably the most important time frame that you guys have to memorize because the peak time, which is 2 to 4 hours for regular insulin. But the reason why this is important is because that's when the insulin's working at level 10, the highest effectiveness, which is going to really lower the blood sugar levels. And that's when you have to go back and assess on your patient. See if you find any of the fight or flight mechanism manifestations, because that means that the patient's becoming hypoglycemic. So let's say that we gave the said insulin regular at 7 a.m., right? And here's 8, here's 9, here's 10, here's 11, and here's 12, and let's say 1. Well, if you gave it at 7 o'clock, the onset is 30 to 60 minutes. So within 30 to 60 minutes, it starts to work. You guys see that? But the peak is within 2 to 4 hours. So if you gave it at 7, 8, 9, 10, 11, okay? Within 2, 3, 4 hours, this is when your blood sugar may accidentally drop a little bit faster than we intended to. So the peak time is 2 to 4 hours, and that means that it'll look like this. See, it's reached its level 10, its highest effectiveness within that time frame. And then eventually it starts making its way down, and then it tapers off. That would be the duration. You guys can look up the duration. I'm not going to focus too much on the duration because the onset and the peak times, in my opinion, are the most important ones that you really want to focus on. But please know the duration as well. So this right here, this is what we're talking about when we say peak time. What are we focused on? We're focused on the probability of hypoglycemia. Now, this is sometimes described as an insulin reaction. This is sometimes known as a hypoglycemic event. So you have to look for these words for these phrases in the question, because if you see anything like, the patient received insulin at 7 a.m., regular insulin, at what time would you assess the patient for an insulin reaction? You know that's talking about a hypoglycemic event. When is the blood sugar potentially going to drop because of its peak time effects? And that's within 2 to 4 hours when it comes to regular insulin. Okay, make sure that you guys know that that's when you have to check on the patient again. They might not even say this. They might just say, when should you assess the patient again? When should you go assess the blood sugar again? Or they might just tell you the patient manifests tremors, or they have a headache or blurry vision. All those are indications. They're telling you, they're giving you hints that the patient's developing hypoglycemia. And you have to act. And we discussed the interventions earlier. Okay, so that's regular insulin. But we have other ones. We also have aspart lispro. Now, make sure you guys look at your books, see what specific time frames they give you, but in a nutshell, the onset of aspart and lispro, I've seen some books that say as early as 5 minutes, but I'm going to go with the generalization. 15 to 30 minutes. That's usually the onset of your aspart lispro. Your peak time is 60 to 90 minutes. So you see how the onset and the peak time are slightly different from your regular insulin. And that's why it's important for us to be able to recognize that these insulins work a little bit faster, so we have to keep a close eye on the patient. So we focused on peak time earlier. Now let's talk about onset. If we gave the insulin at 7 o'clock, at what time, if you gave the patient received aspart / lispro, the logs that I was discussing, at 7 a.m., which of the following time frames would be ideal for the patient to begin their meal? You're going to get questions something along the lines of that. And so you understand that the onset is 15 to 30 minutes. That whole meal time that they're talking about, that's what it's asking you. What's the onset? You have to know the onset, because you have to understand that medication is starting to go up within 15 to 30 minutes after the administration of the insulin. And that's what the onset is for. When are you going to feed your patient? The peak time is 60 to 90 minutes, meaning that the patient will peak time within an hour to an hour and a half from the administration of the insulin, and then it drops and it tapers off. This medication's duration, aspart lispro, is a little bit shorter than regular, but nonetheless, their concept is very similar. The concept is the same. Again, peak time, what could happen? Hypoglycemia, low blood sugar. The onset, what's that for? It's when you're going to feed your patient. And let's do one more. Let's do NPH. Well, NPH is known as your intermediate acting insulin, right? And by the way, NPH is also either Humulin, it'll have an N, or Novolin, it'll have an N. And that's how you know it's NPH. It's the cloudy one. So the onset for NPH is usually 2 to 4 hours. That's when the medication begins to work. And your peak time could be anywhere from 6 to 12 hours. Some books say up to 14. Just keep in mind that some books' peak begins at 8. Just understand the concept. Make sure you guys refer back to your book, the one that your school or your facility has given you, so you can abide by the facility policies. Okay? So you give NPH, if you give it at, let's say we gave it at 8 a.m. The onset asks you when you're going to feed your patient. So you should be feeding that patient within 2 to 4 hours, 8, 9, 10. That's when it starts working. And it reaches its peak time within 6 to 12 hours. So you have to understand it'll be all the way up here and then all the way, and it'll start going down. The NPH can last in excess of 12 hours. Again, make sure you guys review your books so they can give you your specific time frames. And that's the part that you guys have to memorize. But the concept is always going to be the same. The onset is for when you're going to feed your patient, and the peak time is for when the patient is going to potentially develop a hypoglycemic event. All right, folks. Oh, we have one more, but I won't draw it up here. We have the long-acting glargine. Keep in mind that your glargine, your Lantus, they don't have a peak time, okay? They don't have a peak time, and we usually give it at nighttime, so it's important for you guys to review those things. Now, continuing with diabetes, we discussed hyperglycemia, we discussed hypoglycemia, we discussed some of the common medications. Now let's talk about your chronic nursing considerations. The reason why I say chronic is because diabetes mellitus is a long-term issue, right? So we're looking for vascular and nerve damage. Remember, the ketones and the glucose and the acids, all that stuff destroys blood vessels and nerves. And when they start destroying blood vessels and nerves, the patient's perfusion decreases. The patient's ability to sense things, their sensation, their afferent neurons, they're not functioning as well because you have a long-term disorder, diabetes mellitus, that's systematically destroying all your blood vessels and nerves. And because of that, the patient's gonna have hypoesthesia. They're gonna have a decrease in sensation. Or we can bundle this up in neuropathy. The patient's gonna have neuropathy. And they're gonna have some degree of arteriosclerosis. Because the nerves are being damaged, the blood vessels are being damaged by the consistent hyperglycemic issues. Now, if you guys recall being at your facilities and when you're gonna give insulin, the coverage of the sliding scale generally doesn't begin until you have a glucose level of about 150, correct? That's because according to theory, as long as the blood sugar is less than 140, there's a low likelihood of the patient developing any chronic, any long-term issues. So generally speaking, at the facilities, which is more of a real-world thing, your sliding scales, which allow you to know when you start giving insulin and how many units you give, it usually starts at 151, or anything below 150, we don't necessarily give any insulin because these issues will not necessarily be happening if the patient monitors their glucose level, if they maintain a consistent overall blood glucose level that's less than 140. That's what your book says. Now, we have to look out for vascular issues, right? Keep in mind, since they can't feel, they can't be assessing temperature of the bathtub or the shower with their hands. They literally have to have a thermometer with them because that's gonna be the thing that lets them know whether they can touch the water or not, because they may put their hand in there, they might not be able to feel the heat, but they may have some damage to the tissues. And if you do have